Good morning. My name is Sorcha McPhillips and I'm the Chief Executive of the Huntington's Disease Association of Northern Ireland. I'm joined this morning by Alexandra Fisher, who's a specialist OT. Alex will introduce herself and then we're going to take a question and answer session. Over to you, Alex.
Morning, everyone. Thank you for inviting me. My name is Alex Fisher and I'm an occupational therapist with the West Midlands Regional Huntington's Disease Service. And I'm an occupational therapist, and my role in the Huntington's disease team is that if people are struggling with their everyday activity of whatever kind, then they are referred to me to see if we can find a solution. Over to you for the questions.
Okay, so we've got some questions that we were asked in advance, and I'm just going to take you through them in no particular order. Am I allowed to drive with Huntington's disease?
Okay, so excuse me, I have actually written this all down because there's so much involved. So if I'm not directly looking at you at the screen, it's because I'm looking at my notes, okay?
Okay.
So, all right, let me get this up here. Yeah. Pretty up to the top. Okay, so this will depend on the stage of your illness and how it is affecting you. So speak to your consultant and let them negotiate with you the best course of action. Driving, even though you may have been doing it for many years, is a complex activity made up of many different sub-skills, all of which can potentially be affected by Huntington's disease. Whatever point you're at, you should let your licensing authority and your insurers know of your diagnosis. If they have any questions, they will ask your consultant. And if there are any doubts, your consultant, in conjunction with your licensing authority, may recommend you undergo a driving assessment to determine the outcome.
Okay, that's great. In Northern Ireland, for information, Disability Action, based in Belfast, undergo driving assessments like Alex has spoken about, and they specialise in neurological conditions as well. So if you need any information on that, just ask any of our support workers and we'll be able to follow up. Okay, so the next question, Alex, is what exercise is best for Huntington's disease? It's quite a broad question.
It's really broad, but okay. So evidence doesn't specify any particular exercise, but does state that any stage of your illness, keeping active and mobile is key for your whole well-being, providing it's safe. And if you are prone to HD weight loss, I think there's been a talk by my colleague Jude this morning on this, that you are taking your calorie intake into account, because people often forget that bit. It will help, your mood, your cognition, and your behavior. I would say that just as with anyone, the exercise or activity should be as enjoyable as you or your loved one may be struggling with motivation. And that's a really, really key thing as well. I would recommend that you look at the advice from our specialist physio colleagues at Cardiff University, where they look at this problem particularly. And I know that they are your competitors, but there's a lot of this on the Huntington's Disease Association website in the UK.
Okay, that's great. I've been cycling for years, but I've started to show signs of chorea. Does that mean that I have to stop?
Well, I guess this is kind of related to the previous question. No, not necessarily, but here's the big but, and it is a big but. Check out if you're safe. Folk with a HD brain often have a different perception of their movement than others. So you might be more or less aware of the movement than other people. Also, if you have chorea, you might well have problems with cognition, such as attention and multitasking problems. So just as driving, cycling is a complex activity, even if you've done it for many years. I recommend that you check it out with a trusted other or a professional and be aware that you might not agree with them. and plan for that, such as getting them to video you, particularly if you are not as aware as perhaps, and there's a difference of opinion. If it is problematic, but you love it, and you clearly do, how can you alter the activity so that it's safer? Make the changes now so that your brain has the chance to adapt, as you may be struggling with the impact of your illness, but also changing itself can become more difficult with Huntington's disease as time goes on.
Okay, so basically some sort of a cycling assessment as such is what you're talking about there.
Kind of, yeah. But you don't have to do it with a professional. You can do it with a trusted other. So when I say trusted other, I don't necessarily mean a loved one. I mean a good friend, perhaps even a person that this person is going cycling with, because often cyclists go out in groups together, don't they?
Yeah.
And they swap banter. And it might be, you know, it might be that one of those people are really good at saying to you, actually, yeah, I've noticed this and I've noticed that. How about we check it out together?
Okay, great. And would stationary cycling be recommended for people with Huntington's disease?
Yeah, totally. Again, it's about, you know, with this this person, it's like, okay, you love this. How can it be made safer for you? And yes, of course, stationary cycling. But again, the big but is, are you safe getting on and off? Are you making sure that your nutritional requirements are still being met?
Okay, great. I'm 19 and I've received a positive predictive test. Should I do anything now with my routine or wait for symptoms to start? And I suppose you're talking about to exercise and things like that.
Yeah, of course. Hi. Well, the thing about waiting for obvious symptoms such as movement to start is that your brain has already made a lot of HD changes. So if you feel you can, do what you can now, but here's where I suggest you start. Number one, if you're struggling with this news, seek out psychological support. If you're not already active, get and keep active. But as I've said earlier, be aware of your HD nutrition. Get a good structure and routine to your life so that you give your brain the optimal conditions to function. Make sure that you keep a diary, perhaps on the phone, with prompts, or a calendar in the same place to help you organize yourself, because those are the little things that people start to struggle with. If you are working or you're at college, think about telling them so that they're aware, and then they can make reasonable adjustments, which is what they're required to do under the law. Okay, because if you don't tell them, they can't help and they can't make those adjustments. And then start to plan for the future and talk to trusted others about the plans so that they know what your wishes are, and then you can write them down and make sure that professionals such as your GP know them. I know this sounds really scary, but many of our patients say that once these things are done, it makes them feel more in control. And that's a really, really powerful thing in HD.
Okay, great. My husband sits in his armchair all day, every day, and rarely leaves the house. Is there anything I can do to help get him to exercise? Or is it making him worse, actually just sitting around doing nothing?
Okay. So first of all, I'm sorry he's doing this. And yes, it won't be helping his HD, as he will be becoming conditioned from a physical perspective and from a cognitive perspective. So yes, exercise will help. But firstly, and if he's not done it already, he needs checking out by a professional for problems with his mood and whether he's in pain or if there's something else going on. Because I think it's very easy sometimes to think that everything is HD, and it's not all about people's HD. So get those things checked out. If all of those things have been ruled out, then it may be that as your hubby has become more poorly, then his neurological apathy, which is a neurological lack of motivation, has increased, and you need professional advice as how to deal with this. which can be really difficult as there are currently no good pharmacological treatments. If it's safe for you to try and motivate him, and I say safe because sometimes these things can cause tension and agitation, try concrete communication rather than abstract choice, which is often difficult for the HD brain. So it's more about, let's do this, rather than shall we do this or this, which is quite a complicated question and instruction, which might frustrate him even more. Then if that works, again, I'll keep coming back to this, and I probably sound a bit like Groundhog Day, but setting up a structure and routine with meaningful activity, perhaps something that you don't actually call exercise, because the language is quite important here, will help, so that he knows what to expect and when to expect it, and that will help with planning and his frustration and any anxiety that's involved. Start small. Do not change it once it's in place. And if you must change it, make sure that he knows a few days in advance. Because again, a HD brain struggles with change and sudden change. And then finally, sometimes people respond differently to others. So earlier on, we were talking about the person cycling and a trusted other, and it doesn't have to be a loved one. It can be a member of a cycling team. But it's about, sometimes he might respond differently to others than to you. So get somebody else involved, or even if you can, perhaps a carer, because I've seen that happen too. I've seen carers come in who are, again, because they have a different role and the person with HD sees them in a different way, they're responded to differently. So that's where I begin.
So it could be something as simple as, we're going to go to the shop and we're going to walk to the shop and get the newspaper every morning.
Absolutely, yeah.
Or engage in some of the other organisations, yeah.
Absolutely, it doesn't have to be about exercise, because sometimes if you name it exercise, people are adverse to exercise and they'll just completely shut down.
Okay.
I suppose the other thing that I would say to this lady is, make sure you're looking after yourself and talking to others about this, because apathy is really, really common, and it's probably one of the most difficult things to deal with.
Okay. In Northern Ireland, we have a number of local networks like the Men's Sheds Association, which is very good for engaging men of all abilities and ages. And there are a number of social prescribing aspects that we're looking at as well, which can help both carers and the individual with Huntington's disease to get more active and engaged. As you say, not necessarily under the guise of exercise, but just being around people and being outdoors and things like that. So that's great, Alex. What can I do to help my mum maintain her independence in her own home? She's starting to show signs of dementia and she's had a couple of falls.
Okay, so worrying time for you. First of all, please get your GP or a consultant to make a referral both to a physiotherapist and an occupational therapist for your mum. But in the meantime, look at her home through the lens of it being a hazard. So this includes shoes, clothing, carpets, stairs, wires, lighting, clutter. Check out her hearing, check out her vision. All of these things need to be addressed and make a huge difference to anyone, let alone a person with Huntington's disease who is starting to develop a type of dementia. Falls in HD increase with dehydration and problems with nutrition. So also get a referral to a dietitian and, if possible, speech and language therapist. Lastly, and hopefully by this time the referrals are, coming to fruition, think about technology. Okay, so you've just said about your mum starting to show signs and also having a couple of falls. So in other words, at this point, how would she call for help if people weren't there? Okay, and sometimes technology can help here. So over here we have, attached to local authorities, services called Telecare, and you can check out full sensors and pendants with them. And sometimes I would say false sensors are the way to go, because sometimes people don't like drawing attention to the fact that they might be falling, or they'll forget to put on a pendant. So actually sometimes the sensors device will actually trigger automatically should something happen. So those would be my go-to things initially.
Okay, that's great. My dad is in a nursing home. He's always very slumped over in the chairs in the day room and has literally slid out of them a few times. The nursing home says they can't strap him in because of human rights, but I'm more worried about him hurting himself. Can I make the nursing home get him a special chair? I found one for Huntington's disease that's £4,500 and there's no way I can afford it. So I guess it's about the responsibility on nursing homes to provide specialist equipment. Is that something you can help with?
I have no doubt that there'll be occupational therapists and services such as yourselves up and down the land who are really, really struggling with this. So if I address the responsibilities of the home first. Okay, depending on where you live, there will be a contract from local equipment services with the nursing home or residential home, and it will say that they are responsible for what equipment that they have to provide. And often it's about non-specialist seating. So in other words, they have to provide armchairs, etc., for their residents, okay? But they don't necessarily have to provide what you're talking about, which sounds like it's a specialist Huntington's disease chair. So that's number one. So obviously at that point it's okay, well, who does fund it? So again, I don't know how your dad's care is funded. So again, over here there are kind of 3 tiers, which are private funding, funding by social services, or funding through health. So actually, if a person is funded privately, usually that's a negotiation between the nursing home and the individual and their family members. Or in that case, it might be, okay, can we find a second-hand chair, or can we get a grant towards that? Okay, so this is still just about funding, not about the human rights bit. Then if they're funded by social services, often or not, again, it will be very much about the contract for what the nursing home is supposed to provide. But then if they're funded through health, what that often means is they have specific needs that have met health funding criteria, and often that gives us a lot more flexibility to be able to apply to health for a specialist chair, which means that it can be funded and that you as a family member or as the individual don't have to fund it. So that's the best place to be. Okay, so it really does depend on the funding streams. However, what we've also got here is we've got this thing that they're saying about human rights. So if your dad understands that he is sliding out of the chair and he understands the risks that he's placing himself at, and he has said to them, no, I don't actually want any help with sliding out, and I understand that I'm injuring myself or potentially injuring myself, and they've documented that, then actually what they're saying is sort of right. That actually they can't, if you like, because he understands, use things to keep him in his chair because it's depriving him of his liberty. However, because your dad is in a nursing home, it suggests to me that actually he's quite impaired, and it suggests to me that maybe he doesn't understand what he is doing. And the nursing home, in conjunction with your local support mechanisms, such as your consultant or whoever else is involved in your dad's care, should determine whether your dad understands what he's doing. And if he doesn't, then there should be a meeting that's held called a best interest meeting. And in that meeting, to which you should be invited, or an advocate of your dad's invited, then there should be a discussion about whether your dad should be subject to some restrictions on his movement to protect him from injury. So that's where I would be going with this. So they can't just say, we can't do this and we can't do that. They have a responsibility to find out whether your dad understands or not. And then there is a process which they go from there.
Okay, that's great. And that might consider things like bed rails and crash mats and other.
Absolutely, it will, which will then also minimize injury in other areas of his life.
Great.
And then once you've done that, you'll then be able to have a discussion about, you'll find out through that process how he's funded, and then there'll be a discussion about how that can be funded. But it might not, at that point, it might be a very simple solution that doesn't actually need you to have an expensive Huntington's disease chair.
Okay.
And actually, they don't all cost that amount of money. There are second-hand ones. There are other types of chair that can work just as well. Again, it does depend on your dad's level of career, your dad's level of control, what you decide in that best interest meeting. And that's kind of where it sounds like you're going with this.
Okay, great. Thank you, Alex. And it's another nursing home question. My sister is in a nursing home. She's 41. All the other people are much older and many are senile. The home is nice and it's the only place within 50 miles, but I think her condition has gotten worse since she's been in there. She doesn't seem to do anything. Can you recommend any activities? Now, we see this actually quite a lot with younger people who, for whatever reason, are in residential care, but we don't have specialist facilities here in Northern Ireland for younger people. So you will have younger people with HD, maybe in a dementia unit. So it's about what activities they could engage in to keep them active and to help them.
Yeah, absolutely. So your feelings about your sister being inactive and it having an impact on her deterioration may well be right. But I don't know your sister and the stage of her illness, despite her age, or her CAG repeat from her diagnosis, which will also be having an impact on how quickly she's deteriorating. The fact that she has moved into a unit where everyone is older than her and probably more impaired. I also wonder if she's low in mood, and that will have an impact on her activity levels too and needs to be checked out. However, with regards to inactivity, we do know that this has an impact. Now, that's been seen through evidence, but that's also been seen recently in COVID. If you think about the lockdowns of nursing homes and the inactivity there and not being able to socially interact, that has had an activity on people as a whole. So, and going from being in the community where she probably had a structure and routine prior to her admission to going into a nursing home where she doesn't, will have had an impact. So again, my Groundhog Day, structure and routine really, really optimizes function in Huntington's disease. The other thing here is that rather like the gentleman who is sitting in his armchair all day, the other thing is that if she's deteriorating, regardless of the reasons, she'll probably be experiencing neurological apathy and cognitive changes, which if the home don't know about and they're used to other forms of dementia, will appear as though she doesn't want to take part, when in fact, it'll be these aspects of the illness that will be stopping her. So mood and neurological apathy and changes, different changes in cognition. So the home need guidance on neurological apathy, cognition in Huntington's disease, mood and activity provision, particularly for somebody who's cognitively impaired.
Alex, can I ask you there, just in terms of the responsibility of the nursing home, presumably they would have responsibility to provide activity or to have some sort of stimulation for all of the residents, regardless of
absolutely they do. As a bare minimum, they do, yes. And I believe that there are nice guidelines on this very thing. There's certainly for us here. I'm not quite sure if they apply the same in Northern Ireland, but there are nice guidelines on activity provision in nursing home care. And that gets me round to, it would be relatively easy for them to apply this with some very simple training. So if I get back to this lady, it's important that the activity is meaningful to your sister, but it's also tailored to her level of impairment. So the home need to be aware that this means this might not mean that she would fit into their hopefully they're providing a basic activity schedule, but they must understand that she might not fit into their activity schedule, and it might need to be more one-to-one activity. Now, this doesn't have to be leisure activity, which I think is often a common misunderstanding. It can be something simple as going into your sister and brushing her hair and being read to, which creates the opportunity for connection, which is really, really important, particularly in Huntington's disease, particularly in neurological apathy. So the tool that can be used, and I would recommend if there are homes listening, is something called the Pool Activity Level, which is a tool that activity coordinators and carers can be trained in with relatively low cost and have a massive impact on the way that we engage with people.
Fantastic. That's great. I'm just conscious that we've only got a couple of minutes left, so
okay,
let's get a couple more questions, and then the rest we could include in our email. So
totally.
there's a few questions looking at specific aids, but I think those are probably best suited to just, we can provide a list of things in the email.
Yeah.
There's one particular question though about sleep. My wife has Huntington's disease and moves about a lot in bed. Sometimes I get no sleep at all. Can you advise anything? I'd rather not have to leave her on her own. So I suppose we're trying to avoid separate rooms, which I know some people do end up with, but is there anything in the interim that could be done?
Okay, so I'm going to go back to, have you spoken to your consultant about medication? Purely because Professor Rickards and I and our colleagues, we'll often talk about this in clinic. And because it is about sleep and it's about sleeping together, sometimes people don't talk about it because it's rather intimate. But actually, if it's impacting on you, then it's really important to address it, because it might be that by just tweaking it a little bit, the movements can be reduced and that will have the impact that it needs. So I suggest you do that. But if you have, and it's still problematic, then the options become very pragmatic if you still wish to sleep together. So first and foremost, it's the space and the width of your bed. Sometimes people find that swapping to a twin bed with separate bedding can help, so your wife is not pulling the sheets and the duvet off you, because obviously if she's moving around, that will happen, particularly if you're sharing the bedding. Movement can be made a lot worse by heat, which is often problematic for people with Huntington's disease. So having separate bedding, which has a different TOG rating for you, both may help. Sometimes being in bed in and of itself can cause anxiety for people. So that could be a worry for her, and that can cause increased movement due to the anxiety. So that needs to be addressed with her. And then finally, it could be about looking about, if it is anxiety, where the bed is, and looking at some such items such as bed levers, for example, which might make her feel more secure. Ultimately, I guess I would say though here that there's a balance to be had, and that's between you being completely exhausted and looking after and loving a person with Huntington's disease, or being refreshed and looking after and loving a person with Huntington's disease. So can you sleep? And I know that you've said you don't really want to leave her alone, and obviously it's not me, but can you sleep in another room for one night out of 3 and negotiate this with your wife and telling her why? because often, again, people are really embarrassed about this particular thing. And sometimes being quite concrete and saying why can really, really help. But I appreciate this is a really personal issue and represents something more than just getting a good night's sleep, because this is a change in your relationship.
Okay, that's great. Yeah, it's really important, I suppose, to maintain the closeness, but you need to have a balance there ultimately.
Yeah.
Okay, Alex, I think we'll wrap it up there. As I
Okay.
said, we're going to follow up with the questions and answers, some resources to direct people to, and there's a few more questions really around specific aids that you might recommend. But in the
Yeah.
meantime, thanks very much for your time, and to all the participants, thank you for your interest in today's session, and I'll be following up in the next few days by email. Thank you very much.